Okay, perfect. Again, I want to thank EFUS for having me to give this talk, Dr. Parekh for getting me on for this. This really is an amazing event that you guys have organized to coordinate so many centers at one time is quite fascinating and interesting, and I'm excited to kind of hear the discussions and perspectives, both from all the different faculty who are on across the country over there. So. Let me see if I can look to move forward. Perfect. So these are some of my relevant disclosures. I do a little consulting work. A little bit about me. So I'm a orthopedic foot and ankle faculty at Emory in Atlanta, Georgia. Did my med school training at Vanderbilt in Nashville, Tennessee, a state kind of north of Georgia. Then I did my orthopedic residency at Atlanta in Georgia, and then I did a foot and ankle fellowship at Duke. And I actually trained with Dr. Parekh, learned a lot from him, as it sounds like everybody on this call has. So I run our orthopedic foot and ankle fellowship. I'm a program director for the residency, and I grew up in the States, was born here, but my family's actually from Bombay, but for my wife's family as well. So my family's in Tardave and most of her family's in Bandra. So, we visit India often, and it would be awesome to get involved with this organization, on a more in-person level as well. So, before I go too far, for most of you on this call, I'm sure this was a phenomenal day and night. I just had a child, and my father-in-law has been staying with us, and I really got into cricket over the past month. And I thought it was phenomenal, the skill required to have this catch. And I don't think I could give this talk without showing this at least one time. So I want to say congratulations to all of you. The drought that has finally ended, and I'm surprised so many people made it to this call this early, because I'm sure most of you were out quite late last night. So hopefully everyone really got to enjoy this. So, I'll start with the case. This is a 17-year-old female coming in with heel pain. She was, enjoying her summer, jumped into the shallow end of a pool. Otherwise healthy female, non-smoker. Her exam's pretty benign. It's closed. A lot of bruising, swelling, otherwise neurovascularly intact. So these are her x-rays, demonstrating a highly comminuted intra-articular calcaneus fracture. She's got calcaneal height loss. When you look at the axial view here, not a lot of varus valgus, but you can really see that her joint is quite compressed and crushed here. So, this walks into your clinic. Initially you see something like this. Most of us that treat these injuries, that see these patients both at the start and long term, know that these are quite devastating problems, especially for a 17-year-old. So, initially this is quite a shock, but once you get past this, what do you do? When do you choose to operate? When do you treat this conservatively? If you decide to have surgery, what approach? Do you try something MIS, open? And kind of what happens long term. So as we go through the discussion today, we'll kind of go through the decision tree of how we go about deciding, where to go with calcaneus fractures. So, a little bit, why are these injuries so bad? A lot of this comes down to the mechanism. These are high energy injuries. A little historical reference, these used to be called, were also called lovers fractures or Don Juan fractures. As you can imagine, somebody escaping a place they're not supposed to be in the middle of the night and jumping off a balcony and breaking their heel. So I'm sure this happens still now, but we commonly see these in car accidents. These are quite high energy injuries. So there's a lot of crush injury to the bones, the soft tissues. There's vascular compromise. A lot of these patients get neuropathic problems because of the neuropraxias that develop, or the injuries to the small nerves in the foot and the ankle. And the main issue here is the articular injury that occurs at the time of the injury itself, that sometimes is just irreversible. So, that quote at the beginning that I showed, the man who breaks his heel is done, is from a JDJS article back in the early 1900s. And even at that time, they'd kind of determined that these are quite devastating injuries from a functional perspective. Even if these heal well, you do everything right, these patients can still have problems. So, again, what makes these challenging. I think the biggest thing is the injury mechanism. This is a high energy axial load on the foot, and this leads to severe soft tissue compromise, articular damage, and these patients often have concomitant injuries too, as we all know, particularly in the spine as well. So, there's a lot of literature that has looked at the kind of long-term outcomes after calcaneus fractures. This is a study published in JBJS up top out of Duke, where I trained, and they looked at 12 years out, and these patients, even after they were fixed, they had a good outcome surgically, their AOFAS scores are still relatively low. It just goes to show the functional consequences of this injury, even when appropriately managed. And again, the study below showed that only 50% can return to work. So again, regardless of how you treat these, and even when you treat these appropriately, these patients have long-term problems. And a lot of times this is an injury. When I see a patient, I spend a lot of time initially explaining to them that, hey, listen, this is going to be a long ride. So getting to the kind of meat of this, the decision tree here. So, calcaneus fractures, as was stated earlier, have kind of gone back and forth. Do you operate on these? Do you not operate on these? And there's a lot of literature to support both. These are two studies, just two sample studies that have looked at operative versus non-operative outcomes. The top is a meta-analysis of a bunch of randomized controlled trials. The below is a randomized controlled trial from 22 hospitals in the UK. And kind of both of these found that there was really no difference in outcomes functionally, but there were higher complications with surgery. So this is an injury where, we have an inclination to always want to fix the fracture or fix the problem, but sometimes operating on these can lead to more problems, and especially if there's not really going to be a lot of functional gain. So there is definitely a role for conservative treatment for calcaneus fractures in my mind, and we'll kind of go through which fracture patterns I feel are best treated with surgery. So these are some of my indications to operate on calcaneus fractures. Again, this is very subjective. I'd love to hear the discussion of the faculty on later. But again, any patient that has any kind of vascular path or any kind of vascular issues, a smoker, uncontrolled diabetic, I'm not operating on their calcaneus. The soft tissue risk or the risk of infection, wound healing issues is simply too high. They have to have an adequate soft tissue envelope. In my mind, that's the most important part of this surgery is getting the soft tissues to heal. You can do a fantastic job fixing these fractures, but if your incision doesn't heal or you get any kind of wound breakdown, it doesn't really matter. So, again, if the two criteria above are satisfied, then the next questions that I ask are, can I make something better? Can you make the articular surface better? Can you restore the height? Can you restore the coronal plane, so varus valgus? The surgery has to serve a purpose. If the articular surface is shot, you can't restore the height, you can't correct deformity, then there's not a reason to operate. And again, obviously, open fractures, tongue types where there's soft tissue concern, these need to be fixed. And again, with this surgery, you're always considering the next surgery or the fusion procedure that a lot of these patients ultimately need, or sometimes they don't have a choice. And that's where restoring the anatomy in terms of the height, getting these patients out of varus is crucial because, as most of us know, dealing with a calcaneus fracture malunion with subtalar arthritis is quite an undertaking. So let's say, you decide that, all right, I've got a calcaneus fracture, I got to fix the two kind of routes or the two boxes I look at next are open versus MIS. So now when I mean MIS here, what I'm kind of referring to is not a true surgical approach. So not visualizing the subtalar joint. So, a sinus tarsi approach or an extensile lateral, I would put into the open bucket. But MIS are things like percutaneous techniques or percutaneous reduction maneuvers to then stabilize the fracture. And then you use percutaneous fixation or placing the patient in some type of external fixator, which I actually do quite a bit of. So Looking at the MIS and X-fix criteria for me, again, soft tissues, soft tissues, soft tissues for me with this injury. If I have any kind of soft tissues that are in the gray zone, I'm worried, is this incision not going to heal? Can they tolerate an incision? Then I'm going to kind of think X-fix or something more MIS. If I have a fracture where the articular surface is well maintained, the posterior facet looks good, but really they're just in varus or their height's lost. Well, that's a good case for MIS or even an X-fix. So, I think with any MIS case, these injuries have to be acute. You can't have callus, you can't have scar tissue that is formed. Otherwise, the fracture fragments just won't move. X-fix, so I work in one of our level 1 trauma centers, and we'll see a lot of these that we just have to X-fix because they're open injuries, they're severely comminuted, there's severe loss of height that you just can't fix. And with this, I prefer a medially based X-fix. So again, this is just a case series that shows the technique that I like. This medial X-fix, you pin in the distal tibia, a cuneiform pin, and then a medially based calcaneal pin. The idea here is with the medial X-fix, you can really maintain your height. You can jack this X-fix to get the height you want, but also keep this fracture out of varus, which to me is one of the biggest problems with calcaneus malunions is the varus that can result that if they're not treated appropriately. So thinking about MIS techniques, again, what I'm thinking about here are percutaneous or closed reduction maneuvers, and then a variety of techniques to percutaneously stabilize this fracture. So this is actually a study out of Asia published not too long ago where, they use large Steinmann pins, as you can see, placed here in the back of the heel to maneuver the fracture fragments, then create a plane posterior laterally between the perineals and the calcaneal bone itself. So you kind of create this dissection posterior laterally and slide the plate. I've tried this technique a couple of times. I've found it difficult to really get the plate over to dissect, subperiosteally to get the plate where you want it to be. But the results in this study have demonstrated that this can be done pretty well. This is a technique actually out of Europe where they use these 2-point distractors that I've kind of shown here at the right. I haven't necessarily tried this, but I thought this was interesting to show. They'd put in 2 pins, one in the talus, one in the transfixing pin in the calcaneus, and then put these distractors both medially and laterally and kind of use these as levers, again, to maneuver the fracture and then percutaneously place screws, across the subtalar joint or to kind of raft the subtalar joint. And again, they perform these acutely because, you're not really making an incision and there's a low complication rate. So now when I think open, again, I'm looking mainly at sinus tarsi and extensile lateral. And again, you have to meet all the surgical indications. The soft tissues have to be amenable to an incision. For me, any kind of articular incongruity or any kind of displacement at the articular surface that we got to restore, I got to be able to see it. That's, again, just a personal subjective thing, but I prefer to be able to see the joint and reduce it well and visualize it. So, and again, more chronic injuries just don't do well with MIS. They're just difficult to mobilize. These fracture fragments just don't move. So going back to our decision tree, the 2 big approaches that I, utilize in practice are the extensile lateral and sinus tarsi. I'm excited to hear about the sinus tarsi approach from our colleague in India. I do a lot of extensile lateral, but I do like sinus tarsi for certain approaches, for certain for fracture patterns, and I would love to hear if anyone has experience on the call with the medial approach or any other open approaches. So again, sinus tarsi, starting at the tip of the fibula, going to the base of the 4th metatarsal, shown here on the left, the extensile lateral on the right. There's some variation as to the longitudinal arm. I like something kind of more halfway between the back of the fibula and the lateral border of the Achilles, and then in line transversely with the base of the 5th metatarsal. These are my emphasis at our institution, just because, everyone is very polarized. Some say that, oh, you can fix any calcaneus with the sinus tarsi. Some need an extensile lateral. So these are fun to kind of incite discussion because everyone really has their own opinion and there's truly not a right or wrong. When you look at the literature, there's tons of articles out there comparing sinus tarsi and extensile lateral. And, these are just three examples. And, when you look at these, the summary statement is always less wound complications, less operative time with sinus tarsi approach. But, in my mind, can you really compare these two approaches? Because they're two very different approaches that should be utilized for very different purposes with regards to calcaneus fractures, which come in a wide variety. So in reality, I don't think one is better than the other. I think it's more about using them in the appropriate indication based on the fracture pattern. So again, for me, or at least my thought process with this is I use a sinus approach except for the following. So if there's significant displacement medially, particularly at the medial facet or the medial aspect of the posterior facet, I find this hard to truly visualize through a sinus approach, especially if there's a lot of lateral wall displacement or lateral comminution that needs to be moved to adequately restore the medial aspect and restore the anatomy at the constant fragment. The other times that I found a sinus approach to be difficult are chronic injuries. These patients swell, and sometimes you have to wait weeks before you can truly get to their fracture. And, in those cases, the fracture fragments sometimes just aren't mobile. The lateral pieces you can get to through a sinus, but medially, if there's displacement that's scarred in, I find that difficult to get through a sinus alone. So again, the approach you utilize has to allow you to accomplish the goal that you set out with, which is to restore the alignment, to do what you can with the articular surface and maintain height, which ultimately gives this patient the best long-term outcome, even if they need a subsequent subtalar fusion. So, again, a lot of debate, and this will be exciting to hear everyone's thoughts on fixation constructs. Do you use a plate? Do you use rafting screws, large cannulated screws alone? Do you do both? Again, tons of literature on this. Anytime I see tons of literature on a specific topic, it usually tells me that there's not a right or wrong to it. And it really comes down to experience, comfort level, and what you feel good about. The consensus is that plate fixation gives you more reliable reduction and maintains your reduction long term. This is a good study actually published this year that showed that plates hold your reduction better than screws alone. But, there is a higher operative time to putting these plates, particularly through a sinus approach. It's tough. You have to you have to create your subperiosteal plane to put the plate. There's wound risks. So it's a technical challenge, but provides a little more stability from a construct perspective. So, for me, it really depends on the fracture pattern. If I'm doing an extensile lateral, I use a larger calcaneal plate that really spans the entire calcaneus, kind of like the bottom left here. If I'm doing a sinus, I prefer to use a sinus or a more sinus focused or kind of a wave plate, as we call it, kind of here on the bottom right. Just because I prefer to put a plate if I can. The only times I've really truly used screws only is in younger patients who have really healthy bone and really large fracture fragments. When you see that large lateral aspect of the posterior facet that's flipped and really there's not a lot of joint comminution, good bone, then yeah, I feel you can fix it with screws alone. But for me, more commonly, I'm finding the comfort level is better with plates. So let's kind of get back to this case. I'll show a little bit of the surgical technique that I like to use for these kind of injuries. Unfortunately, I don't have a video of her case, but I've got some good fluoro shots that hopefully can be of value to you guys. So again, 17-year-old girl at a pool party, jumps into a shallow end of the pool, smashes her heel. Again, you can see the level of articular damage and joint compression and height loss she has here. A kicker I didn't tell you before was that she's about 3 weeks out. She was turfed around to a few pediatric hospitals. The ortho peds guys didn't feel comfortable taking care of her. She's kind of more of an adult, although she's not 18. So ultimately ends up in my clinic 3 weeks out. So, this piece kind of scares me a little bit when I look at this kind of axial view. There's something going on there at the medial aspect, her medial wall, just that there's a piece flipped that I'm kind of already thinking, how am I going to get to this laterally alone, through a sinus? So when we look at her CT scan here, you can really kind of see this flipped piece I'm talking about. If you look as I scroll through these cuts, there's a large part of her facet that's actually flipped and rotated 90 degrees. So, as I'm scrolling through this, I'm thinking, all right, this is a healthy 17-year-old female, a lot of articular displacement, some of which we can't fix, but, there's significant height loss. So, bad injury, but, we can make this better with surgery to give her a good long-term outcome, or at least better than treating it without. So definitely surgery for her. She's 3 weeks out with the level of displacement, not really a candidate for MIS or X-Fix. Now, if she had presented to us acutely, would I have considered X-Fixing her? I probably would have. I would have thought about X-Fixing her, restoring her height, keeping her in the X-Fix for a couple of weeks till her soft tissue is resolved, and then consider surgery then. And then again, here, sinus extensile, I would love to hear from our sinus tarsi expert overseas as to whether this can be managed with the sinus tarsi approach. Just because I think with the level of displacement medially, this is one where I, would think an extensile lateral is best. But again, would love to hear the thoughts on that. So, again, we went with an open reduction internal fixation with an extensile lateral approach. Again, the key here, as I've kind of stressed in an annoying fashion, is the soft tissues. This approach is notorious for wound healing problems, particularly at the apex or tip of this flap. The lateral calcaneal artery provides most of the blood supply to this area. And that apex or that tip of that flap is a watershed area. So you have to be very careful retracting this. I don't use any retractors here on the skin. Minimal retraction from like SINs or Army Navies. Thick flaps, full thickness flaps down to bone with the skin, with the initial incision, and immediately elevating this flap over, taking everything with it. And as soon as I get to a place where I feel I can feel start to feel the talus, the anterior aspect of the calcaneus, and even the fibula, I go ahead and put in these large 2-0 Steinmann pins you can see here. I put one in the fibula, one kind of in the talar dome, and one in the talar neck, and I bend these up. And I use these as my retractors so I don't have to touch the flap. I have an assistant who's every couple of minutes putting some saline on this flap to keep it moist. And again, flap protection is key with this. So for me, this allows you direct visualization of the entire lateral aspect of the calcaneus. Again, this image here on the left is after we've exposed everything. We've put some K-wires in to kind of provisionally reduce the posterior facet. And you can see the level of bone loss here with this injury. I mean, it's quite remarkable. When you fix a lot of these, you start to see how much, the impact of crushing the bone really does, particularly when you get their anatomy restored. So again, these are more fluoro shots. Again, here showing axially, we were able to, take the lateral wall. I completely take it off, put it on the back table, remove any of the lateral facet, put it on the back table in a wet saline gauze, keep it nice and moist on the back table, and then work medially, build the medial aspect of the calcaneus, particularly the articular surface, and work laterally. So that's what we're doing here on the left. You can see that we've kind of restored the medial aspect of the calcaneus. And again, more images here showing top right, more of the articular surface restored. These are lag screws that I place once I get the posterior facet reduced and restored. And I usually like to fill my void with cancellous chips. I'd be interested to hear what everyone else is using, whether you take bone graft or not. But in a healthy 17-year-old, I fill this defect with cancellous chips. And again, using a large calcaneal plate to kind of hold everything in good alignment. So, her axial alignment looks good. We're able to restore her height. So in my mind, we've kind of taken a very bad problem and done the best we could with it. So, of course, like I said, the wound is the biggest problem with these. And, she's 4 weeks out, super healthy 17-year-old girl, still had a little skin edge necrosis at the flap. I kept these Algauer Donati sutures in for close to 5 to 6 weeks. A little wound care, local, some PO antibiotics. Ultimately, this healed, but you can see even in a healthy patient, you take all the precautions you can, and sometimes this is still a problem you see. So that's why surgical indications are crucial for these injuries. She's 1 year post-op. She's a couple of years out now, but I haven't seen her back. I think she moved or went to college or something. But she at the time she was a year back to all her activities. But again, she's only 18. What's going to happen 5 years from now or 10 years from now, right? A lot of us see these patients in their 40s, 50s with terrible subtalar arthritis, and who knows what's going to happen to her. But I think the key here is her alignment is maintained, her height is reduced. So if she does get subtalar arthritis, which she will, but if she gets symptomatic enough warranting an arthrodesis, we've made that procedure much more simple and likely to have a good outcome. So, thinking about calcaneus fractures, these are terrible injuries. They can have devastating consequences functionally to the patient. This is an injury where sometimes not operating is the best route. Complications can occur. You can get wound healing issues. And when patients get wounds with these problems, with these surgeries, they are not easy to heal. And you can go down a bad road sometimes that can end in an amputation. So you got to be importantly cautious when choosing which patients to fix. MIS sinus approaches are great. I'm excited to hear the next talk on the sinus approach. But you got to be careful of the drawbacks or the things you can't do with these procedures. And again, you got to remember the goals of maintaining height, alignment, and restoring the articular surface the best you can. And counseling patients, these are patients you spend a little bit of extra time with, really explaining to them that this is a bad injury. And even with the perfect surgery, there are still probably going to be some functional consequences. So again, I want to thank, you guys for having me do this. It really is an honor to speak to all of you, and I'm excited to hear everyone's perspective, and I'll take any questions at this time.
Dr. Rishin, thank you so much. We will take the questions at the end of this session after we hear to Dr. Kashyap also. And thank you for great analysis about the factors, how to choose MIS versus open. Thank you so much. Now I request Dr. Kashyap to talk on Indian perspective of how we manage on the fracture calcaneus. Over to you, Dr. Kashyap, sir.
Is my screen visible?
Yes, sir.
Okay, my sound audible?
Yes, sir, absolutely. Please go ahead.
Thank you, moderator sir, Sampath sir. Thank you, organizer of this event, Raja sir, Rajiv Shah sir, and Selen sir. Thank you, Corona, for giving me opportunity to present my work. So my job of building a platform is made very easy by Rishin, because he has almost given all overview about the calcaneus from the history to the current perspective and the future perspective too. So I'll be directly jumping onto the technical aspect of calcaneus displaced intra-articular fracture by a sinus tarsi approach. My presentation is divided into two parts. In the first part, I'll give a step-by-step technique in a case. And second part, I'll do a video real life surgery kind of a thing. So both the cases which are chosen are a kind of an elementary type of case, which are good to start by the people who are new into this. So minimally invasive, I got a new definition from Rishin today, because I was considering a sinus tarsi minimal. Now I'm pushed to open. So that's a correct way, because the future probably lies in what Rishin says. So the steps of sinus tarsi approach for intra-articular displaced fracture calcaneums are: first we do a good exposure, then we start with articular exposure, then we correct the varus correction of the heel body of the calcaneus, then we do posterior facet elevation, the height of the posterior facet, and then we do a definitive fixation, and then do closure. So these are the simplified steps which over a time by evolving myself from doing extensile lateral approach and then going to sinus tarsi approach. So these are little bit different than what all the books and literature says, but these are very simplified. So these steps can be done, and calcaneal anatomy can be restored in say most of the 70-80% of the cases, which in a person who is starting into fixing this should select elementary kind of cases. So this is a first case. This is an intra-articular displaced fracture with a posterior facet which is gone inside the body. The calcaneal height is reduced, and there is an intra-articular component. This was operated using a sinus tarsi approach, and this is what my final fixation was, right? So that's, I'll take you step by step how I did this. So that's my OT setup. Patient is in a lateral decubitus position. I am operating from the opposite side. The IATV comes from the front at the angle. And the first step is to visualize the intra-articular views which are required during surgery. And that when we start the surgery, before we actually inflate the tourniquet, we need to see, we can see these three views. The first is a lateral view, good Harris axial view, and a broadened view, right? So this is my incision. My incision is bit longer than what is usually been advocated, and it is bit obliquely going down toward the calcaneocuboid joint, because I believe most of this case has a fracture going into anterior process into calcaneocuboid joint. So if we take it little down, then we can actually visualize that part also. So this was the initial skin marking, and then the subcu, and the first thing which we identify are the two peroneal tendons, so that once we identify that, we can protect it well. Then we gradually start dissecting anteriorly into a sinus tarsi approach, where we do a clearance of the soft tissue, then the muscle, abductor muscles, and the sinus tarsi fibrophytity. That way, we start seeing that. And then I create a soft tissue tunnel in between the lateral wall of the calcaneum and the body, which is tunnel for the placement of plate. So if I do my dissection at the start, that step is electronic plate. At this stage, I need to release a calcaneofibular ligament from the calcaneal side. I don't cut it, because if I release from the calcaneal side, it will heal again. So that's the exposure. See my intra-articular, any of the blunt. If you can see my cursor there, if you see cursor there, that's a fracture part which the posterior reducing it now. In this case, I hit the joint using a lamina spreader. The lamina spreader between talus and the anterior, can use the Hintermann, which will be shown in a, simply use a simple retractor tool. That's an intra-articular which is done. Once that is done, that is transfixed with the K-wire. Usually I use two, here it is one. So once the posterior facet and the posterior articular block is constructed, that part one is over. After exposure, the articular reduction is done. Then the second part is a correction of heel varus. I simply do my correction of heel varus using a 3 mm K-wire, which goes from the back of the heel to the body. When it was halfway, then I correct the varus with the force of the drill itself, and then I put my wire anywhere into the midfoot. Like say here it is going into a calcaneocuboid joint. So that will correct my heel varus. And the next step, I will use the same to elevate my posterior facet. So now I'm putting laminar spreader between the which is fixed with the K-wire and which is down there. If I use my laminar spreader in this wire, then probably I'll break calcaneal wall, inferior wall. So this makes support on which I can do my in this small clip. How nicely it is being elevated. Then once that posterior facet is elevated, then I put a transfixing wire, which is a threaded 2.5 mm K wire, which goes from the body into the subtalar joint. And that time also I keep my
YouTube में आपको चलते रहेगा.
That time, when I'm putting my 2.5 mm K wire, when it goes through the body, again I apply some varus correcting force. So the varus correcting force is used second time, and then I transfix my subtalar joint so that my height is maintained. Once that is transfixed, I can remove my lamina spreader, and now we can see in the third right slide that the posterior facet is now not going down. So that's how lamina spreader, but height is maintained. So that's my varus facet. So at this stage, my overall anatomy of the calcaneal is corrected. Now it is a surgeon's choice whether to go only with the K wires, or as Risin said, only with the screws, which we can do, or what I do usually is a plate fixation, right? So at this stage, the correction of overall anatomy has to be recreated. So now I use my soft tissue tunnel, which I have used. I use plate, and then I slide my plate through the sleeve which I have created into the soft tissue and put it inside. Initially, I sized that plate by putting it just over the skin and seeing under CM. That's how I put my inside the tunnel, and first screw which I use is a compression screw, which is a partially threaded screw. And why I do that? Because I can put my plate flush to the bone when I compress that screw. At the same time, I can compress my intra-articular portion also. So once that is done, I start fixing with the locking screw. Usually for the apex screws for the body, I don't do only percutaneously. I do a small apex incision, like a kind of a part of the extensile approach, and then I put all the screws one by one. And lastly, I will replace my partially threaded cancellous non-locking kind of a screw with a locking screw, because my job is done. If I add a one locking screw, then I can add a stability to it. So that's my final picture of the recreated calcaneus, where we can see a nice posterior facet, articular reduction, and that's how I close, right? So that's the final fixation picture. All the views, a lateral, a broaden, and the axial view, and there is an internal rotation, axial kind of a view. So that's how I do. That's a step by step. Now what I'll do next is I'll present a video, which is a different case. So the case is, she's a 19-year-old girl, fell down from a height, and she had actually fractured both the calcaneus, but I am demonstrating the left one. So these were the pre-operative imaging. So if we look at the X-rays and the CT scan, there is a displaced Sanders kind of two kind of fracture with a wide gap at the posterior facet, and this was the post-operative picture which I created. And these are the pre-op as well as the post-operative CT scans, wherein we can see that a nice intra-articular reduction, no step at the articular part, and there is a good elevation. So almost a normal kind of geometry is created. So this was the introduction of that case. I'll unshare first to come out of my PPT. Then again, sharing myself for the video, which I am going to do. Is my video visible?
Yes, sir. Please go ahead.
So that's the case which I just spoke about. So these are the pre-op images where there is a posterior facet broken into half. Usually we see this fracture, there is a fracture line which exit into anterior process of the calcaneum. These are the trolley, and there's a different type of the plates which we keep ready. We usually do this in a lateral position with a tourniquet. So these are my marking. That's my incision which I use. I don't go beyond the tip of the fibula or lateral malleolus posteriorly. And that's an apex incision which I take. So that's a incision. As soon as I do a skin and subcu, I first find my peroneal tendons. Sometimes we can see the anterior branches of the sural nerve over here, and if we look, if we see them, we need to protect it. But I don't hunt for that. That's an anterior process of the calcaneum which is now visualized. I am clearing off the content of the sinus tarsi and the adductor muscle and fibrofatty tissues from there. That's my posterior facet started being visualized, and that's a peroneal muscle which I look for. I usually decompress and open both the peroneal tendons. That's one, and the second will be just beneath that. So once I see that, then I just remove that septum, because anyway I'm going to put a plate over there. Now that's a calcaneofibular ligament, right? So some people simply cut it, but I feel that if we erase it from the bone on the fibular calcaneal side, that's a good chance that it can heal again. So that's a calcaneofibular which I am releasing from the calcaneal side flush to the bone. Now I distract the joint to visualize my intra-articular work. So I'm using Hintermann in this case. The previous case I used the lamina spreader. So that's a 2.5 mm pin into talus, and that's an Hintermann. Now the second wire will be into an anterior process. Sometimes that is broken. You can use a large Hintermann one, which is designed by Rajiv Shah sir, and you put it into the calcaneus body also. So once we distract, we can see the posterior facet, the fracture and the articular part. We clean the clot and everything from that, give a wash there. And once things are clear, we use blunt instruments to reduce that, right? And I use artery, or here I use a small scoop and this bone pusher, right? Once the bone pusher, the articular reduction is okay, I use 1.8 mm 2 wires. Why I use 2 wires? So that we don't rotate on that. So these are the 2 wires. So my first step of doing intra-articular reduction and temporary fixation is done. At this stage, now the joint distraction is no more required. So I'm removing my Hintermann. Removing the wires of Hintermanns, because now no more it is required. So how beautifully we can see the posterior facet and articular reduction. Now I am creating a apex incision, which I take as a small part of the extensor lateral approach. You can see where my apex is with the artery, and I take the flap like we are doing that extensor lateral approach, like a plastic surgeon erasing their flap from the bone, flush to the bone. It has to be full thickness so that soft tissue complication doesn't happen there also. So create a tunnel of soft tissue from both the sides, one from the body side and then one from the above side also. For that, I can use a sharp small periosteal elevator, and we have to see that because there is a very flimsy lateral wall. Sometimes we can go inside the wall. We have to take care that we remain outside. This is how I have created a tunnel for my plate fixation. Now I will do my varus correction. This I use a 3 mm K wire passing from the body, that I will, once it is through the body, I will do a valgusization of that, and then I forward my K wire into the midfoot anywhere so that it is fixed to some normal bones. I can rely on them. So now then the second step is I describe into the PPT that I use a lamina spreader and elevate the posterior facet of this. And I take, help of the K wire which was there put for the varus correction, because on that we can actually solidly elevate. Otherwise, the inferior wall would break. Again, a posterior facet fixing wire, that's a 2.5 threaded wire, which you can transfix. You may not if it is a strong bone. And so once that is done, then there is an anterior process fracture also that I've reduced with the anterior part of the incision, put a temporary K wire till my plate is fixed. So at this stage, my calcaneal anatomy has to be, normal. If there is some bump, I can simply punch it out so that my lateral wall is flat. You can see these all the intra-articular, we almost, a normal kind of a calcaneus made there, right? Now I put my plate, pass it there into the tunnel which I have created. That's how I put my plate, and that's apex where the plate is now coming. I put a temporary K wire, check under IITV, everything is right, and then start fixing it. So the first screw which I use is a partially threaded screw, but still I use that screw through the drill sleeve only, because that a future locking screw is to be put. So once that tunnel is created, I put a partially threaded 4 mm CC kind of a screw, which goes on a guide wire. So that's a screw which I use, and you will see the effect how this screw actually make the plate flush to the bone. I've taken little extra time on this, because if you see that the plate will so nicely compress itself to the bone, so there is no lateral one. At the same time, if there is some intra-articular compression required, that also can happen. And that screw is kept till the last. Then all the interior process, posterior facet and the body locking screws are put initially with the power, then tighten with the hand screwdriver. We can use a small spike behind the for the putting the posterior most screw, retracting the calcaneal fibular which was already cut. We need to go there because posterior screw is difficult without calcaneal fibular. Again, see the plate is little off. What I am doing is with my spike, I make a plate flush. There is an elasticity into the plate, which if you do this way, at the end when you remove the wires, it can add to your heel valgus. That's how it is fixed. One by one, all the screws are put. Then wires are removed once I am satisfied. Lastly, I'll remove that screw because the job of that screw was compression, but that will not give as good stability as the locking. So it is replaced with the locking screw at the end. And then all the things are cleaned well. We can see that if we use a plate, this much of the subtalar motion, which is possible with the inversion, eversion is possible. So at some time, not fixing a plate would not give this benefit of mobilization. So this is a post-operative picture, and that's how I close in 2 layers. Sub-Q, I use undyed 2O vicryl, and at the apex, sometime I use that apex sutures, which are modified plastic surgeon kind, Algover Donati kind of a suture, which we use commonly in a extensile lateral approach. I try and keep my knots outside of the middle bridge of the skin, taking every small care to prevent a soft tissue complication is probably the first aim in operating upon calcaneum. It is better not to operate than to do any soft tissue complication, as Rishin said. So that's apex suture, which we take, Algover Donati kind of a suture. That's how we finish the surgery. And usually, the soft tissue problems are not very, very common if we do meticulously. These are the post-operative X-rays, and these are the post-operative CT scan too, showing the nice intra-articular reduction. The post-op, I use a back slab for 2.5 months, but I often to do subtalar and ankle motion. And usually weight bearing is allowed around say 2.5 months or so. That's what my protocol is. Thank you.
Thank you, Kashyap sir. Excellent video demonstration. Now we have 6 minutes for some questions and answers. I can see your first question. How will you assess a reduction on table? So, Rishin, any of your tips to assess reduction intraop?
Yeah, again, with an open approach, you're kind of directly visualizing the subtalar joint, the posterior facet. So I'll sometimes take a freer, and I'll kind of take a freer across the subtalar joint to see if I feel any kind of, divots or any kind of step offs. So, using an instrument that's not going to damage the cartilage aside from visualization. Again, the 3 views that Kashyap mentioned, Broden's view to see the posterior facet under fluoroscopy. Harris heel axials are crucial. I think the combination of direct visualization of the joint itself and radiographs for me are how I kind of assess. Sometimes I do get contralateral films if the anatomy is weird, just to kind of see what their height is like on the other side. But for the most part, restoring the posterior facet gives you connecting that to the anterior part gives you a good idea of what the height needs to be. So
that's a great point. What he said is a combination of direct visualization and radiological views, both. But you see, intra-articular part best visualized intraop if you're opening it. And he said all the components like intra-articular step, varus, valgus, length, height, that is what is more important. So those are great points. Kashyap sir, I want to ask you one question. Now, Rishin was very clear when he is going to opt for MIS and when he is going to opt for open. So I want to ask you, when you are not going to have this sinus tarsi in your cases, when you will not opt for sinus tarsi in your cases?
Yes, that's very good question, and probably partially that was answered in Rishin's talk. If there are some medial procedures to be done, say it's an open fracture, or if there is a sustainculum tali fracture which is fixed, then it's done from the medial. And second thing which I would do is, if there are some cases which needs a primary fusion over and above to fixation, so that's not the case for sinus tarsi. Thirdly, the sinus tarsi is not the direct approach which anybody is going to jump and do it. So a surgeon has to evolve himself from treating a simpler calcaneus fracture with extensile lateral approach, then treating complex fractures with the extensile lateral approach, and then going to using a sinus tarsi to a simpler fractures. So if there are any complex cases where we need to put a lot of bone graft, primary fusion, or if there is any doubt, see, my advice to, in all the fractures, we should not marry to one thing. We should not, keep our ego high. So we have to be open to the things. But that's a very much personalized, because if now I have got a case of Sanders 3 or sometimes 4, I can go with the sinus tarsi. But for people who are starting, should go with the young patients, less comminuted, intra-articular Sanders type 1 or at the most 2, and should have some exposure to the extensile lateral approach when they are done.
Yeah, very well said. So that don't get married to only one ideology. We should be open, and particularly in calcaneus fracture, patient factors and even surgeon factors, injury factors. These three things are important. What injury needs, what patient as a comorbidity needs, and what surgeon knows. Rishin, I had one more question. You said sometimes that a lady would have come to you in emergency, you would have put her in fixator. So
Yeah.
typically external fixator, if you put day one as a spanning fixator, how many days you would not be, you would be very comfortable that you won't have any pin tract infection subsequently? Because when you're going to do some sinus tarsi or some open technique, you're always worried about those pin tracts. So
Yeah, that's a good point. It's a great question. I don't think there's a true science to it. When we fix comminuted, severe pilon fractures or distal tibia fractures, we'll put these patients in X fixes, and, we do our best to not span the, our plate with the potential pin site, so put your pins proximal. But, there's not a lot of literature that supports that. It's kind of more just a thought of, hey, it makes sense, right? But in a calcaneus, it's tough. I don't put X fixes a lot on calcaneus acutely. The main reason I would do it is, let's say the patient, a lot of times these patients come in, they have concomitant injuries. So, they'll come in, the calcaneus fracture is the least of their problems. They come in with abdomen injuries, and they're going to be in the ICU for weeks. You don't know when they're going to be cleared for surgery. So in these patients, when they go up for their acute, open abdomen surgery, putting on a quick X fix maintains the height, right? And so if you're not going to get a chance to get back to them, or if they have a lot of injuries, it helps. To answer your question, I typically will wait until the soft tissues are ready. So, I think, Kashyap had a great, the wrinkle test, seeing the skin wrinkling. I'll keep the X-Fix on until it's time, and I'll take it off at the time of surgery. So I don't do anything special for the pins or the pin sites. I kind of treat it like I would a distal tibia or a pilon.
yeah, great. So we have utilized full our allotted time, and thank you so much, both of you. You have shared absolutely good points. I always tell my fellow colleagues, never start calcaneus case unless you see a good axial view, and never leave OT unless you see a good Broaden's view, because that tells you everything. It is not only the intra-articular component, as Dr. Rishin said, it is all what you are supposed to do. And then, as Dr. Kashyap said, don't marry to only one ideology. Whatever you can do, all these things by the preferred approach, you should do it. So thank you so much for enlightening on this difficult topic.